Hi everyone, I'll just give it a few minutes for people to come along. We're about 4 minutes to 9 o'clock when I will kick off. Thank you. Let's just get things up on my screen that I need to see. Hi again, Tim. Nice to see you. Easy day. Thanks for tuning in again. All right. How's that looking? Is that a little bit bright? I might just turn this light down a little bit. And we might turn this one down as well. Is that right, Tim? Right, let's see. Where are we? Okay, if you're online and you feel like saying something, if you could let me know that you're here on the chat column here, that would be really nice for me to see, just to make sure I'm not talking to the ether. And I'll give it a couple more minutes and then we will go. Thank you so much to, yeah, no, there's not a lot I can do about that because I'm, thanks Tim, I'm just streaming from the YouTube webcam setting, but yeah, I'll probably try and get a different setup once I've perhaps figured that out a little bit more. I've only really just started live streaming. Hey Sam, how you doing, man? Nice to see you. Excellent. All right, and thanks to the Science Media Centre for retweeting this as well. So hopefully we'll have a little bit of reach there with some people who are working in the health media. That would be good too. Thanks, Tim. How? Like, I've seen a picture of you. I don't think you really need that, do you? Hey, Sarah. All right. Just a minute to go. Hi, Zoe. Nice to see you here. Thank you. Yeah, you call it a haircut. Yeah, I'm sure that's right. Okay, it's 9 o'clock. It's time for me to introduce myself and what it is that I'm going to be talking about today. So thank you for joining me tonight. My name is Dr. Saab Johal. I'm a clinical psychologist based here in New Zealand. And I've been working in the field of psychosocial support and recovery in disaster since 2006, including a stint as associate professor in disaster mental health at Massey University here in Wellington from 2011 to 2018, where I was the lead writer for the UK Pandemic Preparedness Plan back in the UK when I was a civil servant there, published in 2011. And I led the teams on the New Zealand plans for pandemic preparedness and psychosocial support and recovery in the case of any emergencies or disasters, published in 2007 and 2016. And I did a lot of work following the Canterbury earthquakes, but also the Kaikoura earthquake as well. So yeah, that's a little bit about me and my professional background and why it is that I'm speaking about this today. And I think there's a lot to think about when considering the impacts on individuals and communities affected both directly and indirectly, and for those concerned about the spread of the coronavirus from that's emerged out of Wuhan in China. I'll talk a little bit about some of those issues on my live stream tonight. You'll have the opportunity to ask questions. I'll check in every now and again to see if I can address those immediately here. And if there's enough interest and we run out of time, or I might need to go out and do a little bit of research, then I can follow up with further live streams to respond to your questions. And also, please, at the end of this, to check in on perhaps some of the detail of what it is that I'm saying tonight, you can check my blog on sarbjohal.com. That's just my name, Sarb, S-A-R-B, Johal, Johal.com. And I'll leave that in the description of the video and in the first top comment when this is published after the live is finished. All right. I want to look at some cognitive biases tonight that might help understand how it alters how we perceive the risk of the coronavirus and how susceptible we might feel like we are to it, and how we might overreact, underreact, and how we can change or calibrate our reactions. But let's start with some background to start off with. Now, many epidemiological experts are predicting a sharp increase in the number of people infected with the Wuhan coronavirus. Not so much in New Zealand, because I think the current thinking is that we don't have the density of population for it to spread too far, fingers crossed. Now, this is all theoretical at the moment. Based upon the limited information that's currently available, it seems as though the coronavirus, I can't say that, the coronavirus has already undergone at least 4 generations of spread, meaning that the virus is already likely to be circulating beyond family members and healthcare workers who've been in close contact with those people who already have been infected with the virus. Now, combining that with new information that large numbers of people are possibly walking around with no symptoms, spreading the virus to anyone who comes in close contact. All this means that containing the spread of the virus is looking very difficult now. And some models are predicting a very challenging start to February. Further outbreaks in other Chinese cities, more infections exported abroad, and an explosion of cases in Wuhan is what we're looking at here. However, it's important to maintain a sense of perspective here. Now, concerning how infectious this new coronavirus is, one estimate of the number of people one person can infect, known as the virus's reproduction number, or R0, R0, is between 1.4 and 4, according to 2 different research groups and the WHO officials' comments. Now, compare this with SARS, which was between 2 and 5, and measles, the most contagious disease known to humans, which is between 12 to 18. And you can see that actually there's a really big difference there. And what we're looking at here is something that has a relatively low rate compared to those other 2 diseases. Let's also compare that with influenza, where we might see quite a few false positives for testing for the coronavirus in the Northern Hemisphere for the moment because it is flu season. Now, the pandemic H1N1 2009 influenza virus had an R0 of 1.2 to 1.6. The 1918 pandemic influenza virus is estimated to have been around about 1.8. And seasonal influenza that we currently experience now is estimated to usually be about 1.3. Now, of course, what we don't know about the current coronavirus outbreak is the fatality rate, or how secondary infections or complications will unfold, or how it will affect people who may already be vulnerable to the effects of the infection. But what we can see is that actually it's nowhere near as infectious as measles. So we need to keep a sense of perspective. And I want to talk a little bit about what the recent experience of many countries and measles might do in terms of thinking about how susceptible or how at risk we might be. Because we humans don't tend to process information rationally at these times. We don't process it, dispassionately on a mere numbers thing. We're fallible, and we can be highly influenced by how events are reported to us through the imagery of people walking around in face masks, or crowded hospital corridors where it looks like there's no staff or they're overwhelmed, and through numbers that we see on screens that are increasing rapidly, confusing us as to the scale or the rate of increase. I want to talk about 2 particular cognitive biases that can influence how we may perceive our risk of susceptibility to the coronavirus outbreak. I'm just checking that not everybody's left. Okay, this is still okay. There's still 11 people on here still. Okay, so the first one here is the availability heuristic. Now, this is the tendency to overestimate the likelihood of events with a greater availability in our memories, which can be influenced by how recent the memories are or how unusual or emotionally charged they may be. So, lots of emotionally charged images and commentary on TV is likely to make the memory of the event more available to us. We tend to remember the events that are linked to emotions, strong emotions, more readily. Therefore, it's going to make us more likely to recall the event and to precipitate either an approach or avoid reaction, depending upon whether we feel prepared or whether we actually want to shrink away from this. And how well we think we might be able to deal with the challenge ahead, which is called self-efficacy. You know, how well am I going to be able to implement the plan which I've got in place for myself? Now, we see this when we think about how we deal with living in an earthquake zone, for example. Some people can take a fatalistic approach and think to themselves, well, it's going to kill me no matter what I do, and they tend to take very few preparation measures. However, for those who are more open to receiving messages that emphasize that little actions can make their chances of survival so much greater, such as having a store of water and food, if they can afford it, that is, and securing items that may fall on them or injure them, they will have a greater sense of agency and feeling that what they can do can make a difference to their chances of coming out of an earthquake relatively unscathed. And of course, the best way to get this information is from a trusted source, preferably from someone or an organization that you've known for a while. And this is why disinformation or exaggeration is such a problem when it comes to dealing and preparing to deal with risks like this new novel coronavirus, which we don't know much about. The second bias I want to talk about is related to measles, and it's called the anchoring or focalism. And now this is the tendency to rely too heavily or to anchor on a, I'll come back to that, Tim, excuse me. Rely too heavily or anchor on a past reference or on one trait or piece of information when making decisions. Now, because many people have been subject to and heard much talk about and discussion about measles outbreaks recently, we could fall prey to the trap of anchoring our thoughts and beliefs on transmissibility of this new virus on the rates that we've seen with measles. However, what we've already seen, what I've already talked about, is that the transmission rate actually looks to be much lower than that. But unless we're given the chance to attend to and to process this information and to consider its implications, fear and uncertainty is likely to spread, which means that we feel far more vulnerable than we actually are. Now, that's not to say that we shouldn't be taking precautions. We should. We most certainly should. But if we're not careful, then we are unnecessarily stoking up and ramping up fears in the community, I think. There's one more bias that I want to talk about, and this is how we take social cues from other people in our environment as well. We pay a lot of attention to what other people are doing when we are uncertain about what it is that we should be doing ourselves, or we have trouble processing the information. We're not sure what we should do. And there's lots of theoretical work that's been done on these information cascades and herding behavior, where when we have obscure or uncertain information, such as in the early stages of a disease outbreak, people may look to the behavior of others as a source of information. And this can lead to large numbers of people coming to the same incorrect conclusions and unhelpful decisions. Now, it's interesting because people don't tend to get panicky about seasonal flu because it's an old risk. We've heard about this lots and lots of times. This tends to only happen where a new disease outbreak is happening, where there's uncertainty or obscure information. And if anything, for seasonal flu, complacency is more the risk. It's on the other side of the coin. So it seems reasonably likely then that under the conditions of high uncertainty, poor information, rapid change of information, and emotional stress that exists during an infectious disease outbreak, particularly in the early stages, people could arrive at significantly biased subjective assessments on key factual issues. You know, these don't become facts. People are actually arguing whether this is true or not, or at least for a time. And this can lead to an overestimation of the infection risk and making less than optimal decisions regarding, any kind of preventative action, such as, people may not comply with quarantine restrictions or requests, or there have been cases where perhaps people who work in the health sector quit their jobs prematurely because they don't want to be exposed to this infection risk, which is blown up out of all proportion in their minds. And indeed, during the SARS epidemics, we saw public opinion surveys suggesting that people at times held excessively high perceptions of the risk of becoming infected with SARS, or if infected, of dying of the disease. But other survey evidence seemed to indicate that people are constantly trying to update and improve their subjective probability estimates. Hey, Stefan, nice to see you. And that comes back to what you're asking here, Tim. Actually, there's a few questions being asked about how the mainstream media should be exercising greater responsibility, and perhaps they're being more accountable for how they report. Well, I think it's difficult for them. It's such a fast-changing situation, and on the whole, I think that people are pretty responsible in how they report it. But I think I agree with you that the role of information and communication in public health policy and response becomes absolutely pivotal. Accurate and timely information needs to be released through official sources to help reduce the unwarranted panic and emotional distress, and to help people form more realistic probability assessments of their own subjective risk. And so at the moment, we don't really know. There's considerable uncertainty as to whether this is going to turn into something bigger, or we're going to be able to contain it and it merely peters out. And so the authorities may adopt a bit of a wait and see approach, especially if an official announcement might trigger all kinds of things, either internally, or what we saw in the Surat plague in 1994 was that there were all kinds of severe trade and travel restrictions that were imposed on India during that time. And it did great damage, not just to what was going on in the region, but also to international relations too. And so nobody really wants that to happen. And we've also got, don't forget, many more unofficial information sources competing for eyeballs. And this information will spread in a viral manner using the usual social media platforms. So it's going to be really difficult at some stage in this outbreak for public health information sources to respond to these. And excuse the pun here, completely different viral challenges that are going to be happening. This is not a physical virus. This is the information viruses that are going to be released out and in the wild, and there's going to be competition for information, and it's going to be actually a contended space. And I think that's something that we really need to watch out for very carefully. What I'm going to talk about now is the idea that actually different kinds of events produce different kinds of reactions in people and communities. So let's say, for example, something like this. It's not a sudden impact event, although there are characteristics of that for this coronavirus outbreak and how it's unfolding. So when you have forewarning, typically you have time to prepare. Although in this case, information has emerged in a very time-compressed way, which has left people appearing to be scrambling to respond. So this kind of event trajectory leaves less time for your plans to be executed. And it actually can lead to more acute anticipatory anxiety about imagined futures with a high degree of uncertainty as to how things are going to work out. We also have an inability to ensure that supplies may be in place, particularly if we're thinking about China at the moment, and the ability for that to be replenished, and also staff load. And the cumulative impact of working in a highly stressful environment starts to take its toll remarkably quickly. Although there does seem to be some evidence that actually for those people who are working in these situations, working for an altruistic purpose does seem to have some protective effect from the worst of the impacts for staff, but it's not complete protection. So we can't take this for granted. Just because people feel like they have a vocation and they're doing this because they believe that it's the right thing to do, it doesn't mean that it makes them immune to the effects of the cumulative impacts of working in a stressful environment. So we can't take it for granted, because what we saw in SARS, in Singapore and in Hong Kong is that actually what we see is burnout. And we see healthcare workers leaving their professions when it's all over. And we really can't afford for that to happen. I'll come back to comments in a little while. Thanks, Stefan. I'll just address that when I come back. What you can also see in communities as well is that you can see anger. And we have seen some reports of that in China. We may start to see some other reports of that in other places as well. Anger in authority for feeling like they haven't performed their task well. What the societal contract says that a government or a health protection agency should do in these situations. There's an implicit unwritten code where as an individual, I'm signing over my agency and protection to you, who I voted for, who govern me, who I've trusted to take care of me. And even though there may not be much that can be done, this anger then gets projected outwards into these agencies. So really thinking about, if you're working for one of these agencies, how are you going to deal with that? How are you going to listen to that so that people feel like that they're heard and they won't just continue to be angry with you until they feel like you've acknowledged that at least you've heard their anger and they can see that something's being done to address the situation that they find themselves in. It's unfair, but it tends to be what happens. So then I'm going to move on to this idea of community cohesiveness as well, because what we see not just on the individual level is that we see whole communities being affected by this. Now, let me be clear. I'm not claiming to be by any means an expert on Chinese culture or the psychology of disasters in China. It's a completely different political and cultural system to ones that I'm familiar with. Now, nevertheless, what I'm going to offer here is some general principles which could be drawn upon to understand some of the dynamics that might be at play currently at a community level in China, and also as this disease expands out of China and how this might play out. And what I'm talking about particularly here is the fracturing and rupturing of community cohesiveness. So we've seen already that interregional and international transport has been severely restricted in China. And there are reports of communities and towns making their own barriers, reportedly trying to keep people out who have originated from Wuhan. And in this, we can see how stigma and discrimination take root and spreads through communities, poisoning relationships that beforehand may not have been perfectly fine, may have been problematic, and it may reopen old sores. But actually, it may actually cause completely new ruptures too. Now, we've seen also in the research of previous infectious disease outbreaks, how health workers who work in situations like this can end up being shunned and stigmatized by their own communities for fear of transmitting an infection and then being infectious and with something that they picked up at work. And this stigma then may be passed on and extended to their family members, such as their children being perhaps treated differently at school or ostracized by their peers, or worse still by their teachers. And we've certainly seen this in New Zealand, and it was reported in Singapore and in Hong Kong during the SARS outbreak too. Now, we know that the best form of protection to the impacts of emergencies and disasters is actually social support. But with the fracturing of communities and travel restrictions, meaning that families who are meant to be together in this holiday period in China, where it may be the only time in the year that perhaps they get together, means that the social capital that would usually exist to help people get through something like this is eroded significantly. And people can feel lonely and isolated and with little sense of when things may return back to normal for them. And further than that, they may feel and experience this stigma and ostracism if they're isolated outside of their home community. So you can see how that actually not only are they going through the stress of perhaps thinking that they're infected, or at least coming under suspicion, perhaps through no good reason, or perhaps because actually, thinking about the way that perhaps some cultures think very differently about how the good of the many outweighs the good of the few. And they're counted in the few in this weighing up of the risks. You can see that actually being isolated from their social support also, then actually perhaps you can see that the load is actually multiplied for them. The next thing I want to talk about, and I'm kind of racing through this a little bit. I hope it's not too fast for people. And don't forget, this is going to be recorded and it's going to be available for you to watch afterwards as well. And I will publish a written version of this on my blog as well. So feel free to check that out afterwards. What I want to talk about now is secondary stresses and secondary impacts. Now, secondary stresses are the circumstances, events, or policies that are indirectly related to or are a consequence of an emergency event, which results actually in emotional strain amongst affected individuals and communities and makes it more difficult for them to return to what is perceived as normality. So examples of a secondary stressor could include things like ongoing financial strain, or conflict in families or couple relationships, or job insecurity, or losing your job. Now, in this case, it's been very interesting. It's been unprecedented what we've seen here in terms of whole regions being isolated from one another. and a travel ban actually being imposed by China on its citizens such that they're unable to move out of the country. So in this case, policies designed to contain the outbreak may actually have a larger social and psychological consequence than the virus itself at this time, or at least at this stage. Now, China's approach is perhaps different, as I've said before, rebalancing the needs of the many against the needs of the few, using a different algorithm or sets of decision principles that we might see elsewhere in the world. That's neither a good or a bad thing, but it does bring about a different set of consequences, perhaps. And we know that the effects of disasters on the already disenfranchised get magnified in times of emergency. And so we can predict that those who have less of a voice or influence may also not do so well compared to others in this emergency as well. And all this fear and uncertainty takes a toll on our ability to cope with an unknown threat. And this toll can be personal as well as falling upon a community that is dealing with the active, direct impact of a virus. Now, this idea of the Chinese government's decision to limit the ability of citizens to leave their country on tour groups means that countries and regions that have economic ties to this Chinese tourism trade, which is huge these days, will feel the impacts. And sometimes it's going to be acute. And this then has the flow-on social impacts upon those affected communities that rely upon that tourist dollar in order to make things work in their regions. And this is how the impact of the outbreak doesn't just follow lines of physical transmission. Okay, it's really important to understand that the attempts to deal with the outbreak also have psychological and social impacts far beyond the origin of the coronavirus, but also where the physical transmission is currently happening. And it can also have other negative consequences. So, for example, we've seen today the Queenstown Lakes mayor in New Zealand said he'd been advised about anti-visitor sentiment prompted by coronavirus concerns. And he's quoted to have said, quite rightly, it's understandable to have concern about this unfolding health issue, but it will never be acceptable to descend to racism and xenophobia. We must all unite to demonstrate zero tolerance in regard to any such behaviour. This is a time to show a bit of humanity and kindness to our visitors. Now, unfortunately, our communities, wherever we are, will have to remain vigilant to respond to such sentiment because stigma and discrimination become really common in situations like this. And it's highly unlikely that anyone who's travelled has deliberately come here with the intention or anywhere of spreading the virus. And in New Zealand, there's going to be a cabinet meeting tomorrow and over further days to discuss powers of quarantine. Now, that's interesting here because that has implications too. And like I've said before, what we're seeing in terms of restriction of movement in China is absolutely unprecedented. So quarantine itself doesn't come without risks. Now, I wrote a paper back in 2009. I'll put the link in the description after I publish this video, published in the New Zealand Medical Journal, outlining some of the psychosocial challenges involved in quarantine, including how many patients experience social stigmatization and loss of anonymity. And many describe the emotional strain of quarantine and being isolated. And if you think, for example, parents may have to confront changes in their normal roles and routines, creating stress for entire families. Most found it difficult to explain the situation to their children without provoking more fear. And healthcare workers felt a duty to protect their own children from being taunted or stigmatized by association merely by being their child. And spouses also felt physically isolated. For example, their partners slept in separate rooms and were subjected to further pressure as they assumed responsibilities for running the house, whilst their partner was working and involved in this healthcare of those people who had been affected directly by the virus and perhaps working in a hospital. So in addition to that physical isolation, healthcare workers also experienced their own stigma, and that had the impact of them being left feeling quite angry and hurt in that situation. And actually that carried over till after, until after the infectious disease outbreak had finished. And they remained acutely aware of other people's reactions. And some people actually found themselves denying that they were healthcare workers at all in order to kind of just get over and not have to deal with any of that stigma. So it's something that I think we have to be aware of as well. These people who are working in these stressful situations also need looking after. So how do we support these healthcare workers who are going to be asked to step up in some shape or form? We're not sure what the low is going to look like. We already know it's high in China, and we suspect that it's going to be high perhaps in other cities where there's a greater density of population, where perhaps this disease may already be spreading, but nobody's actually sure quite yet. Now, for those healthcare professionals who are working in these dangerous conditions, the best practice is to make sure that they've got accessible and timely referral pathways, who, for those few, may require mental health services. Now, we know in a traditional kind of like emergency, 80% of people are kind of okay. They may have some kind of reactions, which are normal, of distress, but 80% of those people are okay so long as they get the social support from the people that they normally get social support from. But what we found in the Canterbury earthquakes is that often people who are working in those situations wanted to shield their spouses and their families from the things that they were dealing with themselves. So perhaps where they would normally go to get intimate support is a channel that's no longer available to them. But then also they didn't want to step forward at work and say, actually, I need help, for fear of being switched to a task which they felt was signaling that they weren't resilient enough or that they weren't coping. So what they tended to do was to carry on without really saying much. And they didn't approach telephone helplines that were offered to them because they're working in small teams and they felt like they could actually lose their anonymity and be easily identified. So thinking imaginatively and creatively now about how we're going to offer support to people who feel fearful for one way, in one shape or form, and where they're not able to access their normal forms of support, is something that we really need to be doing to make sure and ensure that these people are looked after through this disease outbreak and come out the other side still willing and wanting to do this kind of work. Because what we don't want to do is people feeling burnt out and the cumulative stress has an impact upon them such that they leave and they do something else entirely. Yeah, okay, I think that's probably what I wanted to cover today, and that's about half an hour's worth of me just talking. So I'm just going to come back here and just check the comments. And any questions that you have or anything that you want to say, please feel free to type in now. Stefan, I'll come back to your point here. Depending on the media outlet, I think is part of the problem. There's also a balance between keeping the public calm and reacting appropriately. Some people are looking to confirm their fears. Yeah, you're right. Often people may be looking for the worst case scenario because they feel like, I want to know the worst and then I want to be able to prepare for that. And some people are outright looking for kind of the conspiracy theory kind of confirmation. And there's something that, there's not a lot that we can do to combat that. It's such an ingrained part of the kind of internet culture these days. It's really difficult to deal with that. And, even engaging with that from a media point of view or from a professional point of view has the danger of kind of stoking the fire and stoking the flame and people turning around and saying, well, you would say that, wouldn't you? Because you're part of the establishment who's trying to cover this up. So it's a really difficult problem to communicate this information in a calm way where you're not going to get shot down by naysayers. And I think that that's just going to happen. And you need to be prepared and understand that actually continuing to reach out and putting out calm, balanced information as much as possible and making sure that you've actually understood what other information is out there in the environment and not being blinkered and saying, I'm just going to do my thing and I'm just going to keep on delivering what I'm doing because that's my job. We actually need to be situationally aware and understand what sorts of stories are doing the rounds and what kind of information that we can put out that either counters that story or asks people to take a little bit of a step back and say, does this actually make sense? Does this actually add up for you? Given this and this other information that also exists at the same time. So yeah, I agree with you. It's a really tricky one. Sarah Jane, do you think there is any importance attached to what name we give an infectious disease? Wuhan feels stigmatizing and perhaps misleading, as it is spreading beyond that region. Yeah, I think you're right. I debated myself as to what to call this, and I've got a subtitle here with a 2019-nCoV. That's really hard for me to get out if I'm just sort of like speaking naturally. But I agree with you. When you tie something to a place, I think it ends up stigmatizing that region or those peoples from that region. And I think if we can make a switch to calling it something different, like MERS or SARS, people don't necessarily associate that with a particular region, although MERS perhaps more so if you kind of like sit and think about it for a while. But yeah, I think what we call it and the language we use is important. So thank you for raising that and pulling me up on that. I have tried to say coronavirus just generally, and I've originated in Wuhan when it's been necessary for me to say that. But yeah, I think you're right. Zuleika, I'm sorry, I think that might be Spanish. If anybody could help with translating that, that would be really cool, because I just, I'm not sure how I'm going to be able to deal with that. Sorry, apologies. I should be more multilingual. I have the Punjabi language skills of about a 3-year-old now. I actually didn't speak English as my first language. Fun fact, I actually probably only started speaking English properly when my grandfather from India came to visit, and he was ex-state army, and he was trained to speak English. And yeah, I spoke English to him for about a year before I went to school, and that's what happened to my language development. All right. Well, thanks very much, everyone, for coming along. If there's no other questions, I will probably call it a halt there. Thanks again. Oh, I think it's something like, how serious is it for the world? Perhaps you can explain a bit more, Sarah Jane. In the meantime, just a reminder, this will go out as a video at the end of this live stream on my channel, youtube.com/The Useful Psychologist. I'll also, probably tomorrow morning now, because it's getting quite late here, put a version of the transcript, which I typed out before I did this video, with an embedded link to the video there as well. Is this serious for the globe? Yeah. It's hard to know at the moment. The clues that are coming out that people are piecing together, there's a couple of papers that are in preprint at the moment, seem to indicate that the number of people who may be walking around without symptoms and spreading this unintentionally may be way higher than we think. And we may be only at the beginning part of this, and we are yet to see the impact of what are known as super spreaders. So these people who shed the virus at such a high rate that actually they end up infecting far more people than those people who are shedding the virus at a kind of normal rate. Now, where these super spreaders end up and how many of them that there are may end up shaping particular disease trajectories and pathways as to how it spreads around the world. I've seen some people, a colleague of mine who I used to work with in the UK government, say that actually, we're kind of beyond containment stage now, and we should be taking, and actually even thinking that we are going to be able to contain this is pie in the sky thinking. Other people are thinking that actually it depends upon how efficient and effective things like quarantine or border checks are going to be. But at the moment in New Zealand, there's no requirement for people who perhaps are showing symptoms of what could be this coronavirus to step aside and quarantine themselves. We can only request that they do so. There's no requirement for them to do so. So Rachel saying hello to each other. Oh, I'm sorry, Rachel. Thank you very much. Is this serious for the globe? So, Zuleika, I hope that's answered your question there. Thank you so much, Rachel. That's very helpful. I should have done that myself. I didn't really want to leave this window, though. Stefan, yes, it is historic to name the first major outbreak of a disease to the region it is first established. Yes, it probably does have a public health kind of precedent there. That's kind of the thing that you do. And I guess perhaps thinking might have moved on from that and thinking about, well, what are the psychological consequences of being associated with being tied to that region? I think perhaps we might be more sensitive to that than we have been in the past. Hey, Sam. Thank you for that. Definite concerns from the front line of an emergency health system that it's already stretched to capacity. Yes, you're right. We've already had a big challenge, particularly in up in Auckland, where we had lots of people who were being worked with after the Whakaari White Island volcanic eruption, and people who are still in intensive care up there. People who worked very hard during that period of time, and that is, of course, the major port of entry into New Zealand for many people, as well as Christchurch down on South Island too. So yeah, we have a very hard-pressed emergency health workforce here in New Zealand ourselves, and I'm sure that we have similar stories going on around the world. This is not an easy job. This is not an easy task that may be facing us in the days and weeks ahead. Again, getting a sense of perspective, we don't really know how this is going to affect people. It may be just actually for most a mild illness, unless you have a particular vulnerability. We need more information before we can actually concretely respond to this in a way that makes sense. But precautionary measures now are definitely necessary. Do you think our pandemic plan thinks of the social support aspect? Good question, Stefan. I think it's there, it's written down. I know because I was involved in writing it and signing it off and getting it through the Ministry of Health and through Cabinet, both in the UK and in New Zealand. Whether people are actually implementing that, and people tend to see it as a nice to have, whereas actually it's core in terms of thinking about recovery and how communities and individuals recover in the medium to long term. Yes, the disease threat and keeping people safe from physical harm is really, really important. But actually, if we want communities and individuals to make a full recovery so that we can have a society where all people are contributing to their potential, then actually it's really important for us to be thinking about social support now. So pre-response, pre-preparedness, we should be thinking about community development, making sure that people like Wellington Emergency Management Office do a lot of work, as do others, around making sure that communities are in a good state and interacting with each other and close-knit as well as they can be in order to meet challenges like these infectious disease outbreaks. So yes, it's written down on paper. I'm hopeful that people have social support in mind when they're thinking about dealing with people in hospital wards, making sure that they have family contact when they're in quarantine. They're much more likely to stay in place and to volunteer to go through quarantine if they can make sure that they have contact with their loved ones, if they know that their loved ones are safe, or if their loved ones' lives are not too badly disrupted. So actually thinking about social work support in order to ensure that people's lives can continue on is going to make it much more likely that people are going to comply with quarantine restrictions, and therefore improving the public health for all. So really, we need to be thinking about it in that way, how social work and social interventions actually have a protective impact upon the public health of the many. I hope that helps with that. How would you message the situation for leading the comms for a multinational company? It depends on who for, I guess. Is it for their own workers, or is it for is it outward facing? Is it to their customers? So are we talking about perhaps a supermarket asking people to think about when they come into their premises? I know that we had incidents locally here in Wellington where during the measles outbreak throughout New Zealand that we often found out that later on, after the fact, that somebody with measles had walked through a local supermarket, and we were sat there scratching our heads thinking, well, we've got a child that's 6 months old, and have they been exposed inadvertently to measles? So thinking on, being on the front foot as a multinational who's involved in running a supermarket, you may be wanting to put out public health messages saying things like, if you're feeling sick, we can help you get your stuff delivered. And then also making sure that those people who are doing the deliveries have adequate protection in order to do that. That way, the whole of the community gets their basic needs met, make sure that food is delivered to those people who need it, yet there's unnecessary risk of infection out in the community for these people who feel like they've got no choice and I have to go out and get some food. So that might be one example of how you can actually think about the internal comms, making sure that your own workers are protected, but also outward facing, making sure that you're contributing in your own way to making sure that public health needs are satisfied too. I hope that makes sense. Sarah Jane, post-SARS, MERS, swine flu, are we getting better at responding to these kinds of situations? That's difficult. I think that institutions like the WHO and the UN are really important in times like this. I think at a national level, we have such a turnover of staff and experience of people who perhaps were involved in the last infectious disease outbreak but are no longer in post. We have consultants who are overworked but who have such institutional knowledge and episodic knowledge as to how they may have dealt with something like this before, where they can lead their junior staff. From a policy point of view, from an emergency management point of view, making sure that we retain that corporate knowledge of how it is that we deal with this is critical. Often we rely upon written knowledge, and actually I don't think that's a really good way of transferring knowledge in a pressured situation to make sure that things are done right. It may work, but often people will just skim read it and do the things that they feel like are the basics, and the stuff that is the stuff that might make a difference later on may get missed, however unintentionally, through the best intentions of people trying to do the right thing. So I actually think that how we learn our lessons, these are lessons offered by how we respond and how we review our responses to MERS, SARS, and all these other infectious disease outbreaks, the research that is done, the reviews that are done. But how we actually learn these lessons and change operationally, or change our policies, or at least tighten the loop between making a policy or making an intervention, then understanding how that intervention has impacted a community or an individual. I think actually we're not great at that. You know what it's like whenever you put in a research proposal, the first bit of money, well, A, you don't get the money that you asked for, and B, the first thing that gets to get cut is the evaluation and the monitoring part of it, because it's seen as a nice to have. But actually, if we make an intervention or if we do a response and we don't understand how that response has gone, we lose the opportunity to then change and learn and see how the next response should be different. I actually think that, to be honest, we're crap at that across the board. We're not as good at that as we should be. Zoe, also, how do we ensure good messaging and preparedness for companion animals for those impacted, or how communities support each other in rural communities with production animals? It's an incredibly important issue, particularly where you have a rural economy, or you have people who are attached to their companion animals and often won't move until their companion animal can move either with them, or they're very reassured that something's going to happen to help them out. And to put them in a safe place too. It's written down. It's there. These things should be being thought about, but often it will take a champion. It will take champions operating at each level. It will take champions operating in each emergency center. It will take champions operating and checking in with people as they come into hospital to make sure that they don't abscond and go elsewhere because they're worried about what's happening with their animals. We need to make sure that we tie the loop there to make sure that actually, because people leaving quarantine situations or leaving before they're well, or at least non-infectious, then that becomes a public health risk, not just for themselves, but for others too. So making sure that companion animals and productive animals are also included in this loop is emergency management 101. Whether it's actually done or not, is often left, I'm afraid, to local practice, where it does require local champions. So networks of people staying in contact with each other, making sure that this is kind of front and center whenever we're thinking about how we are meeting the whole entire needs holistically of people who are affected, communities that are affected, then this is on the agenda too. The long answer. Okay. Anything else? Also, just have a cup of tea and catch my breath. How many people are still online? Let's have a look. Get this out of the way. Okay. All right. I think we are done for the night. Thank you so much for joining me tonight. If you think that this was useful and your colleagues may benefit from watching this and seeing what was talked about, then please do. I encourage you to share it. That would really help me out as well. It's been really lovely for you to be here. Oh, we got some more. Yup. I'm not sure if I made a mistake pronouncing your name. I apologize. Hi, Saab. How do you think that we can better use technology for community to self-seek answers to their concerns and also safety alert authorities if they're feeling sick and don't want to spread the risk by going to the hospital? It's a good question. I was reading about the case the other day. I think it was yesterday. I'm not sure. I've become very time compressed over the last few days, where somebody had just returned from central China and they'd heard that Public Health England were looking to contact people who had just returned from central China. And in this notice that he came across, there was no contact number as to how they were going to contact Public Health England. And he was kind of like searching around and he spent ages trying to figure out who he should contact, how he should contact them. And he sent emails, and I think he copied in the Director of Public Health in the UK health agencies, and he got no reply. So one of the most basic things that you need to do is to, if you're looking for people to report symptoms, is that you have to have a central point of contact so that you can understand nationally what's going on, what's the pattern that's emerging in various different parts of the nation. And you have to staff that. You have to have adequate resource to make sense of the information that's coming out, number one, and number two, to act upon it, actually do something about it once you understand the information you're getting in. So in terms of better using technology for the community to self-seek answers to their concerns, I don't think sometimes we're even doing the basics well enough. In terms of having a central point of collection, making sense of that data, and making sure that people can contact us effectively. Now, I think that there are many ways in which you can do that and have an interface that is friendly that people can use in order to contact and reach out for you. But let's make sure that we do the basics right first. Stefan, okay, there's more questions coming in. Can we evaluate the difference between centralized and decentralized response systems to review the appropriate response techniques? I'm sure we can. I'm sure if we had enough data, I'm sure that would be possible. I'm probably not the right person to be asking as to how we can do that, but I think that depending upon the system that you have, if you compare, say, the Australian system, where you have state and territory governments reporting up to a federal government, it's far more complicated and many more structures to go through than we have here in New Zealand, where it's actually relatively simple. Yes, we have many DHBs, and yes, they're all reporting up to the Ministry of Health, and we have other agencies involved there as well. We have MPI, we have people coming through ACC, perhaps, for I can't think why, but for one particular reason or another, involved in something like a disease outbreak. But in other jurisdictions, they perhaps have many more complications. So I think it kind of internally, that might be quite interesting to kind of like do, whether we can compare that nationally against each other. I think that health systems can be quite different from each other, and you'd have to somehow take that into account as well. This frame rate's really slow, isn't it? Like, look at that lag. Okay, it's 10 to 10. It's getting quite late. Are there any more questions? I will wait for another minute because there does seem to be a little bit of lag from when I'm getting a question and when I'm saying I'm about to leave. Okay, I'm going to start doing a countdown. Going in 5, 4, 3, 2, and 1. Okay, I'm going to call it a halt here for tonight. Thank you so much for joining me. Please share the video and get in touch. You can contact me at helpme@saabjohal.com. You can contact me here and you can contact me on Twitter as well @Saab. Thank you so much again for joining me. Good night, everyone. Stay safe and go well. Pomariye. Thank you, Sarah Jane. Good night. Yes, end.